Hello, everyone. I want to welcome you all to Pediatric Grand Rounds. Got a great Grand Rounds today, and I'm going to hand it off to Dr. Maya Lodish to introduce our speaker.
Hi, I'm delighted to introduce Dr. Michael Harris, Professor of Pediatrics at Oregon Health and Science University, where he serves as Chief of Pediatric Psychology. In 2011, he developed Novel Interventions in Children's Healthcare, or NICH, targeting the triple aim of healthcare reform in youth with complex and chronic medical conditions who also experience significant social vulnerabilities. Through NICH, Dr. Harris has shown that we are able to improve care, improve health outcomes, and reduce cost. And Dr. Harris has received funding for his research from the NIH, the American Diabetes Association, the Helmsley Charitable Trust, and Juvenile Diabetes Research Foundation. The NICH program has proven to be so successful in Oregon, as you'll hear today, that we are bringing it to the Bay Area. And despite challenges posed by the pandemic, we have successfully launched the program here at UCSF to serve our patients with diabetes. And I'm especially thrilled today that we have among our attendees a number of California state leaders in healthcare, specifically in healthcare policy, who share our passion for improving the outcomes for the patients we serve. And we hope to work as a team to make the NICH program sustainable for the future. Thank you and welcome, Dr. Harris.
Thank you very much. Make sure I'm sharing my screen. Is this screen being shared? Maya?
No. Not yet. No, not yet.
Okay. Sorry. Okay. So yeah, I'm going to talk about NICH, and in my title, you probably noticed what some people would consider a pejorative when talking about patients. That was obviously purposeful, and hopefully it got a reaction out of you. Bottom line is that words matter, and unfortunately, the words that we use to describe this population are filled with pejoratives. I came from WashU in St. Louis was there for about 15 years, and we used to refer to these patients as train wrecks. People use the word frequent flyer almost like it's a privilege. And I use the word loser not because these patients are losers, but because our system treats them as such. And the system is so broken that they end up losing, frankly. And so it's the system that is the problem, not the people. I have no relevant financial disclosures, of course, an emoji because I have teenagers at home. I want to recognize my co-developer and clinical director, Kim Spiro, and David Wagner, who is our research director. They are key players in this. It really does take a village. And while I'm speaking about it today, there's lots of people who've done a lot of work on this program. I'd also like to recognize the interventionists and supervisors that actually do the work and work with these patients. It's an incredible group of individuals from all walks of life. And as you can see, who wouldn't want to work with one of these really incredible individuals. So this is the problem that I've been working on for the past 10 years with NICH. And that is that there's a very small sliver of youth who come into our hospital, it's Dornbecker Children's Hospital, who account for a disproportionate number of charges that our hospital incurs, and a disproportionate number of them are Medicaid. And if you can see, it's about 650 youth who have 4+ visits. And I've done some analysis of those 650 youth who've had 4+ visits. And conservatively, based on their diagnoses and their presentation in our hospital, I could probably guarantee you that about half of those were avoidable. And so now we're down to about 325. That's a lot of avoidable hospitalizations, and that's a lot of money that the system is incurring that we don't need to incur. So what's the current state of affairs of our care models and our research? It seems like the vast majority of research and care is targeting a very small sliver of the population of youth that are served by our hospital. It's about 12% of youth, and they account for about 12% of healthcare expenditures. They get care from their PCP, they have a specialty doc, medical social workers, and then maybe someone like me, a pediatric psychologist or behavioral health provider. And most of our research is targeting this population as well. We have lots of intervention research. It's all downstream. It's all been done in randomized controlled trials. We're able to demonstrate changes in assays and labs and health outcomes, some complications from health conditions. We can improve self-management within the confines of these RCTs. And then you move up this pyramid of care needs, and what you see is that 48% of expenditures are accounted for by only about 4 to 5% of our population. This is something that anyone who's working in healthcare finance appreciates. And what we basically do in terms of our care model is, you can see the green region is we just throw more people at them. So not only do we have what we normally provide, the 12%, but then we add care coordinators, home health nurses, community health workers, just thinking that if we have more providers involved, more specialties, that somehow that's going to improve their health and change the spend. Unfortunately, there's no coordinated or coherent care model that we are governed by when we provide this. And then if you move all the way up to the top of the pyramid, that top 1%, which accounts for a quarter of our expenditures, we really have nothing to offer them, and we really do them a very big disservice. And then if you look at this population in particular, but just in general, there's a ton of evidence around the impact of health and health outcomes that are down upstream, social needs, the context in which people live, neighborhoods, communities, social inequities, health disparities, but there's really no interventions that address these challenges in this population. So just to give you a sense of what we're dealing with in Oregon, and this is exponentially smaller, obviously, than what you have to deal with in California, but we had a group that has done a really deep dive into our youth who are covered by Medicaid. We have about 1 million covered lives in the state of Oregon. We accepted money from the feds for the Affordable Care Act. So we expanded the coverage from about 600,000 to about 1 million. And the state itself is 4 million people. So about half of those kids are Medicaid covered, either through CHIP or Medicaid. And if you just look at the kids who've got 3+ social vulnerabilities and either have medical complexity or a non-complex chronic health condition, we're pushing about 50,000 kids who are at risk for a deterioration in health, for repeated hospitalizations, and who have significant social vulnerabilities. So what are you doing about this? What are other institutions doing about this? Some people are doing this. Some people are doing this. And some people are doing this. So nobody really has a care model for these young people. This is what we're all doing, frankly, is treatment as usual. We provide information and resources like nobody's business. When a young person comes into the hospital, is struggling to manage their health, this is what we offer. We have a lot of educators, we have a lot of very good physicians, and we basically give them as much information and resources that we possibly can. Some institutions have psychologists and behavioral health support, and so we do a little bit of how. And very little of what we do involves the social ecology or the why. the context in which they live in terms of providing them support and understanding the lived experience that potentially is driving their repeat hospitalizations. So this is what our care model is in terms of NICH, is we turn this all on its head. So back to the downstream, upstream, you can see that we are really focused on upstream issues. We believe that the social context, the social ecology, if you will, has a profound impact on health. And you can look in the literature, there's thousands and thousands of articles demonstrating this, but nobody's really ventured into this arena to try to address these things. They just seem so unwieldy. We do a fair amount of how, so we have some pretty comprehensive behavioral interventions. And frankly, we do very little of what. We're providing very little information and resources. The vast majority of people understand what they need to do. The vast majority of families appreciate the challenges that are in front of them and how to best manage their children's health. And frankly, just giving them some resources is really not enough, because these families tend to be immersed in and underneath a mound of social challenges that you could just never fathom. So what came out of this was NICH, not niche, but people like to call it that. That's okay. It's novel interventions in children's healthcare, and I developed it to address really the quadruple aim, not just the triple aim. So everybody knows about the triple aim from Don Berwick that addresses healthcare reform in terms of reducing costs, improving care, and improving health. And then the added aim of the quadruple aim is to increase staff satisfaction and provider wellness. So NICH is not for everybody. NICH targets the most socially vulnerable and the most medically complex. This is, although I'm a pediatric psychologist by training, this is not a behavioral health intervention. This is an intervention targeting young people who have a chronic health condition, have medical complexity, and have health and possibly have special health care needs. We're particularly interested in the high cost patients, but we're also interested in patients who have multiple medical conditions. Teenagers tend to be referred quite a bit to NICH because just by virtue of adolescence, it is a very difficult time to manage a chronic and complex health condition. We see a number of NICU grads and youth who are also experiencing mental health issues and substance abuse challenges. And then on the other side of the equation is the social vulnerabilities. These are all the things that we know have a profound impact on people's health. Ethnic minority status, immigrant families, low education, low income, rural families, non-English speaking, families lacking support, single parent families, families who experience insecure housing, food insecurities. I mean, the list goes on and on. And so this is where NICH comes into play, is that we're looking at the most medically complex and vulnerable who also experience social complexity and vulnerability that ultimately impacts not just their health, but utilization, cost, and care. The NICH model is actually very simple. We really draw on 3 different areas of intervention. One is at the family and systems level in terms of teaching families problem solving, proactive skills training, helping them navigate a broken healthcare system. Being on the inside of the healthcare system, I have a bird's eye view of how to get around things, how to access care, who to talk to, how to manage insurance issues. These families have no clue and are excluded from that. And so we help them to understand how the system works and how to help their family access care and solve problems when care becomes an issue. Or it's 24/7 real-time support. Who knew that if you give families access to somebody who can help guide them through the process of managing a problem, that you could divert them from a deterioration in health, some sort of catastrophic health issue, or a visit to the ED or the hospital. Then we're also in the healthcare system. We're a liaison with the healthcare team. We're a liaison with the PCPs. We help people navigate the health system. We're in clinics with families. We go home with families. So we bring information to the medical team about the true challenges families are having. And then we assist families with, when they go back home, how do they in real time implement what it is that the medical team is asking them to do. We help with transportation, medical supplies, durable medical equipment, anything that involves the child's health. And then lastly, we're involved in what a lot of people would consider case management. These are the things that for many of us are background noise. For these families, it's front and center. Involvement in child protective services. You know, our system, I don't know about you all in California, really has nothing to offer. Our child protective services has nothing to offer these families. There's very few medical foster homes that are willing to take a 13-year-old with type 1 diabetes or a 15-year-old with cystic fibrosis or whatever. There's lots of emergency nursery homes, but very little when it comes securing a supportive environment for a young person with a complex or chronic medical condition. We are involved in drug and alcohol treatment, helping families access those for both caregivers and children if they're struggling with these things. We address food, housing, economic insecurity. We help with cultural barriers and language barriers. We're in schools. We're really everywhere families are in helping them to navigate those challenges in their lived experience. And one person does all this themselves. So the interventionist is basically the ninja who navigates all these things for a family. They're command central. They're not a behavioral health professional. They're not a medical professional. They're incredible problem solvers. They're first responders, and they help with navigating all these challenges, ultimately to help stabilize a child's health. So really one of the cornerstones of what NICH is all about is not necessarily about appointment attendance or anything like that, or you know, getting somebody stable housing. The core of NICH is about adherence to complex and chronic medical regimens. Now, if getting stable housing is a key component, as we've identified as in stabilizing a child's health and helping a family to adhere to some complex medical regimen, then that's where we are. So we're intervening at every single level, proximal to the child's health and also distal. A lot of our interventions have nothing to do with the family, have nothing to do with the patient. Oftentimes we're intervening at the provider level. Oftentimes we're intervening at the systems level. This is where we are vastly different than other programs that are trying to deal with this population. I'm going to tell you about patient zero, just to give you a flavor of some of the things that we deal with. This is a patient who kept coming into our PICU repeatedly, and the intensivist who was working with this family came to me and asked me what we could do. I told him that we had got some funding to pilot this program called NICH, and he said, great, let's sign them up. And so this is a 14-year-old female, type 1 diagnosis at 5.5 years of age, had a DKA when she was 10, and then a second DKA when she was 14. A1C is largely unremarkable. Even the 2011 A1C doesn't scare me. You know, I see a lot of kids with A1Cs that are 14 plus. So this is when when the intensivist who was working with this family got really, really concerned. This young person had 22 admits, 12 at our ED and PICU, and 10 at outside hospitals for DKA, 22 in 1 year. You know, for those of you who don't work in the type 1 diabetes arena, you know, the number one cause of death in children with type 1 diabetes is a DKA. It also has the potential to leave lasting cognitive impact through cerebral edema. So even though we can clean these kids up when they come in for DKA, put them on IV insulin, the lasting impact can be really profound and remarkable. So once we got enrolled in this, or once we enrolled this family in our program, this is what we found. And this didn't surprise any of us. The teen wasn't in school. Mom has her own chronic health conditions, suspected depression. Mom, teen, and the 3 younger sibs live with friends. They were all over the place, living on couches. Mom doesn't work. Teen's bio father was in prison for dealing and now lives across the country. So mom doesn't have any help. Mom's various boyfriends are suspected of involvement with drugs and dealing. There was a concern that the teen is being trafficked by her mother's boyfriends. There was a previous open case with child protection, but nothing really happened. The family shares one cell phone, and the teen cares for the younger siblings during the day. We're not sure where mom is. So now those 22 DKs make total sense, right? How on earth can this young person and her family successfully manage diabetes behind the backdrop of all of this? And, you know, there's a lot of this going on, but we don't ever see it. And so this is where NICH is really a critical piece of getting into the community, getting into the lived experience, and seeing really what's going on. Because frankly, when they came into the hospital, even for the, you know, repeat DKAs, I oftentimes was consulted to go see them in the PICU. For lack of a better term, they cleaned up pretty nice. And they were suspect of us, so they weren't going to share really all the true challenges that they were having. And so once, like I said, they enrolled in NICH, we were able to identify there's a lot going on that had nothing to do with diabetes that needed to be managed and remedied before we could even start to chip away at some of the diabetes challenges this young person was having. So this patient and 22 others were included in a pilot. The diagnoses are on the left side there. A lot of type 1s, CF, cancer with GVHD, short gut kids, pain, pulmonary hypertension. But the most important piece of this is the top of the slide. And I'm sorry, the pilot outcome says 2008. It shouldn't. It was 2011. But the year prior, these are not charges, these are expenditures. 23 kids accounted for $1.3 million worth of expenditures at our institution. During NICH, those same 23 kids costs our institution $583,000, or the system, I should say. That's a difference of $750,000 in just 23 children. So this is what got the attention of our other Medicaid providers. We have CCOs in our state instead of ACOs, and we started to establish some contracts. What's the saddest part about this, to be honest with you, is that, you know, we talk about the triple aim or the quadruple aim. It's really the single aim. I've been doing this for 30 years, working with some of the most challenging young people with complex and chronic medical conditions. And while I've always obviously been employed and people appreciate my work, nobody has ever been that interested in what I do until I developed NICH. And only because I believe it's because we move the needle on the money so much, not because we're changing the trajectory of their health, not because we're changing care models, but because we're helping the system avoid costs. This is some social complexity data of our families. This is just a snapshot of some of the challenges they have, but close to 2/3 of our families have either unemployment or underemployment. A lot of food and housing insecurity that has increased exponentially since COVID. A lot of transportation issues. 54% of our families in NICH had an open case with DHS when they were enrolled. 100% of our families have had a case in the past. So DHS or your Child Protective Services doesn't have an answer for this population. At the caregiver level, we saw a lot of challenges with caregivers around criminal history, mental health challenges, drug and alcohol, domestic violence. I think some of our data around complex and chronic medical conditions in caregivers was just extraordinary. I think somewhere in the neighborhood of 60 to 70% of our caregivers had their own medical conditions. If you go up to the criminal history piece, this is an important piece that I learned that I didn't know, that if you have a felony, you don't qualify for Section 8 housing. So how challenging and cruel is that? You have a child who has a complex or chronic medical condition, you made some mistakes in your life, and you don't make a lot of money and you can't access Section 8 housing. A lot of these families are living in cars with children with medical conditions. It's really, really unforgivable. And then on the child side, we see a ton of child trauma, a lot of child mental health challenges, children who have drug and alcohol issues that have been involved in juvenile justice. So you can see that the complexity of these patients on the social and psychosocial level is quite high. The average number of social complexities that our patients have in NICH is about 6 to 7. So can you imagine having, one of these is overwhelming, but to have 6 or 7 of these or more is just, I can't think how people, keep their kids alive and keep themselves alive. And if you think back to that slide about the Oregon Medicaid data, remember that was just families who have 3+ social vulnerabilities. So we have a lot of high risk, high needs, high cost kids out there that need something different than what the system is already offering. This is also what I would say is a pretty remarkable slide. These are data from Oregon in that 53, actually upwards of 60% of our population are youth of color, either ethnic or racial minorities. This is remarkable in Oregon because many people know that Portland itself is the whitest city in the United States, and the state itself is one of the whitest states in the United States. So this is both sad and encouraging data from my perspective. It's sad that youth who are either ethnic or racial minorities are struggling as much as they are with their health. It's encouraging that we were able to get NICH to the most vulnerable, underrepresented, underserved populations. So that's really quite reassuring to me. In doing kind of a deep dive into our cost data, what we realized is there's really 4 categories of cost when it comes to delivering NICH. So there's an expected cost reduction case. These are high utilizing kids who we know we can move the needle pretty rapidly in terms of their cost. A young person with type 1 diabetes who's had repeat DKAs, I don't want to minimize the challenges, but we can move that pretty quickly with the right kind of intervention in their lived experience. Chronic pain kids who come in for IV Dilaudid have been scoped 1 million times, and they just keep costing the system a lot of money, and there's not an answer for them. Then there's expected cost increase young people. The goal of this is to improve adherence so that they could possibly get listed. This would be a transplant case. We get all our kids transplanted at Stanford for livers, and we've had a number of them on NICH who were never listed and would never be listed until they got enrolled in NICH. We were able to get them listed and get them transplanted successfully and then follow them after transplant. I think that's money well spent. You saved a life. It costs the system more money, but all for the right reasons. Then we have stabilization cases. These are cases where, and you may scratch your head like, high level of psychosocial risk, isn't that all NICH cases? Well, some of them are so high that we're not even focused on the acuity is so high for the child, we're not focused at all on cost. And so these cases, we just want to stabilize them first before we start addressing cost. This would also include cases where the medical condition is a progressive condition. We know the person's going to need a fair amount of hospitalization. CF would be an example of that. And ultimately, once again, we move towards reducing utilization, but initially in these cases, we're not. And then the last category, which I always thought was the smartest one to invest in, but what we found with our CCOs in the state of Oregon is that it's the last one that people want to invest in. And I kind of understand why, but so these are prevention cases. These are cases where the spend really hasn't hit the books, but every provider who works with these patients is very, very alarmed by their social situation. And it's just a matter of time before something catastrophic happens and the spend goes, through the roof. And so the problem with getting these funded from our payer partners is that there's no guarantee that this is going to happen. Once again, most healthcare providers are keenly aware of this population and really keeps them up at night. But we struggle to get contracts to cover these kids. An example of a prevention case that we actually were able to get funded for was a teen mom who had a 2-year-old daughter, and the 2-year-old daughter was diagnosed with type 1 diabetes. So Medicaid was keenly aware of the outcomes for teen parents. And then to add a complex medical condition like type 1 diabetes on top of that in a 16-year-old young woman in her daughter, 2-year-old daughter, that presented something that I think the insurance company was really ready to support. But then there have been other situations that we weren't able to get prevention coverage. A good prevention case in cancer would be a child who'd been treated for AML, a teenager, and they successfully got through a pretty rough treatment of AML. They're in the maintenance phase, so they're feeling good. They got through treatment, but they have to adhere to the maintenance meds at a pretty high rate. Otherwise, there's a pretty significant concern for relapse and then possibly bone marrow transplant, which is very, very expensive. And so we approached the payer, a young person, a teenager who lived in a very challenging social situation, who had successfully gotten through treatment for AML. And we said we were really concerned that this young person was going to struggle with the maintenance phase, and they decided not to support that. So what about our outcomes? Let's start with the one that everybody wants to know about. Does NICH reduce costs? These are data that collapse all cost cases, so cost increase, stabilization, prevention, and cost reduction cases together. And as you can see, these are PMPM data, so per member per month costs. And you can see these are all from our Medicaid partners. So in 80 patients, we had an average spend prior to NICH of about $70,000 a year, which a PMPM would be about $5,700 a month. And during NICH, we saw a reduction down to $3,200 per member per month, which translates into about a $40,000 annual savings. So the difference is a $30,000 difference between the year prior and the year during. We also have data that carries out after they're discharged, and you see a reduction of about $20,000 to $15,000 annually, reduction again after they're no longer in NICH. We also see reduced costs in terms of hospital days per year, and you can see the year prior, our NICH cases are averaging about 22 days in the hospital, during down to about 7, and then after down to about 3. In terms of length of stay, we're also able to reduce length of stay by about a half. And I'm learning this along the way, but the hospital benefits by reducing length of stay. They obviously don't benefit by keeping kids out of the hospital, but my understanding is that most patients incur most of their costs for a hospitalization within the first 24 to 48 hours of a hospitalization. Then it starts going down exponentially, especially if there's a DRG that's negotiated with the payer, where you just get a flat rate for, say, a DKA. And we're able to cut that in half, and that translates, based on our analytics, to about a $42 to $100 per event savings for the hospital. It also opens up a bed for a higher acuity patient when there's a need. So if you look over the last year, we did some analysis in terms of how much we've saved in just the patients that we served in the last year, and it's a 51% savings. Basically, the year prior to the year before this analysis, 50, 60 kids cost about 50 kids, cost the system about $2.5 million to about $1 million in the year during NICH. And so the potential savings of what's less lost is basically $1.2 to $1.6 million in potential savings. We also saw almost a 60% reduction in length of stay. So we went from 7.3 days per year in this last round of analyses down to about 2.9 days. So cutting it in half, which then saves the hospital a significant amount of money. And then we've also seen a 50% reduction in ED visits. We had 188 ED visits the year prior in our last cohort of patients, and then only 95 visits the year during NICH. This was particularly critical more recently because we had to keep beds open for COVID patients. We also wanted to keep vulnerable kids out of the hospital and out of the ED during the pandemic. And so this was particularly helpful to our institution. And then this translates into costs as well in terms of utilization. These are just youth with type 1 diabetes, and you could see across all metrics of diabetes admissions, DKA admits, PICU contact, DKA related PICU contact, huge changes. So some are cut in half, which is just incredibly remarkable that we were able to keep these kids out of the hospital and not need intensive care in managing their diabetes. So does NICH improve health? These are A1C data for our type 1 patients. You can see they're down 1% or more in both all cases, prevention cases and intervention cases. So we are moving the needle on A1C. If anyone knows anything about A1C in type 1 diabetes, it's extremely stable across time. It's really quite hard to move. So some people may say, well, they're already, I mean, they still have A1Cs that are elevated, like in the 10% range or around that. Yeah, but the trajectory is moving in the right direction, and there's huge risk reduction in terms of complications for every 0.5% of movement on A1Cs. So it's pretty remarkable that our interventionists were able to do this. This is also pretty incredible in terms of ZBMI. These are 3 failure to thrive cases, and you can see that it was a year out. Like things didn't line up exactly how I'd like, but it was a year out that they were tracked in terms of their ZBMI, and all 3 cases who had failure to thrive demonstrated an increase in their ZBMI across time when after NICH was involved in their care. This is a really incredible one single case of a young person with CF, and you can see each of those spikes is a clean out, and there's a lot of them. And on the left-hand side, it's FEVs, so basically just their lung capacity. And this was the time during NICH. So there was only 1 hospitalization in a year of NICH compared to these multiple hospitalizations. And you could see that the FEVs were stable across time. So this young person didn't experience a reduction in lung capacity. What was unfortunate is we approached the payer for another year of service because we felt like this young person was still quite vulnerable. And they decided not to pay for another year of service. And you could see what immediately happened is the FEVs dropped down to 60%. Right after that happened, the patient was re-enrolled in NICH, and the insurance company paid for that case again. But the damage had already been done, and in CF, this is really a critical thing we want to avoid. How about improving care? So we developed a care model that, or a care evaluation that is not a satisfaction measure. It is actually tracking changes in care. So you can see some of the items, been more frequent communication between the patient and the care team. The quality of the communication has improved. Family has displayed improved adherence. They're coming to appointments. Caregivers are more involved in care. Perception of the family from the provider side has changed and improved. Family that the physicians feel that they're more effective with patients and families, less conflict with the healthcare team, improved care coordination, and the families getting access to more resources. So we have not just providers complete this, but family, parents, as well as patients who are of age that can complete this. And across the board, we're demonstrating improvements in care. And then the last of the quadruple aim is increasing staff satisfaction. Clearly, our providers are significantly less frustrated with the limitations in helping patients prior to NICH. Once they get into NICH, providers just feel so much more effective with families and less frustrated around the care of a very small handful of young people who are on their caseload, who are taking up a lot of their time, and much of it is unbilled. The quality of life for providers improves exponentially. Burnout and lack of retention, as most people know, costs the system a lot of money. I don't know the exact date on this, but I heard that onboarding a physician is, to the tune of about $1 million with everything that's rolled into that: recruitment, onboarding, everything, maybe more for all I know. And then with COVID-19, it also has exacerbated burnout because we're all working that much harder under very stressful conditions. And our most concerning patients are being successfully managed with NICH. So it kind of takes one more piece off of a provider's list of concerns or challenges, because they know that these really vulnerable families and patients are receiving NICH services. And we reduce burnout by improving the relationship with the medical team and the family. Once again, no provider gets into this business to have a conflictual relationship with a patient or a family, but it happens. It happens to me, it happens to all of us. And so we're able to kind of change the trajectory of the relationship. And we make NICH makes provider time more efficient. So doctors and nurses are doctoring patients and nursing patients, not being psychologists, not being lawyers, not being care coordinators. They're doing exactly what they were trained to do. And so everything happens in a much more efficient way around this population. And the last one, even though this is not a part of the quadruple aim, but is an important piece to why I developed NICH, is reducing health disparities. These data are comparing urban and rural youth. Oregon is a very rural state. Most of the population is on the I-5 corridor between Eugene and Portland. And as you can see here, this is just data on admissions, but you can see the year prior in the blue bar in both urban and rural youth, and then the first year after NICH, and then the second year after NICH. All those are going down in terms of their number of admissions from the year prior to their involvement. So helping not just kids in the urban area, but in more rural areas, reduce utilization. And these are admissions by days, and it's very similar, reducing the amount of time that these young people are in the hospital, which helps families because they have to take time off work, and many of these families have parents who are hourly employees and basically lose income. They have multiple children that they have to care for, so they end up having to come up to Portland with 3 kids, and it's financially not good for anyone. In terms of health disparities around BIPOC youth, these data will be presented at the American Diabetes Association. And as you can see, the red circle indicates unserved BIPOC youth and NICH served BIPOC youth at time 0, so before NICH was ever implemented. What's remarkable here is, look what happens to those 2 lines when NICH is involved with BIPOC youth. BIPOC youth go from being having the least number of outpatient attendants to having the most once they're involved in NICH. And then the unserved BIPOC youth continue to have the least amount of outpatient attendance. So NICH is moving the needle on these health disparities in terms of access to care and getting people into clinics more successfully. And then we had, not that we have to have more, but we had the wildfires and COVID and social unrest in Portland. And we had 1 family lose their home due to wildfires. We had 2 families remain displaced due to wildfires. 54% of our families have a member in the family or a child who's immunocompromised in the home. So that created incredible stress for families around COVID. 14% of families didn't speak English fluently. And so there's a higher risk in these families of misunderstanding public health messaging. Not that the public health messaging was really clear around COVID, but add language barriers and you just have a recipe for disaster. And so we were able to intervene in that way. We had 33% of our families lost employment because of COVID. And so we were able to help support them and figure out ways to help them access resources. 15% reported it food insecurity, and then 15% reported difficulty paying for rent. You know, once again, all these things NICH was involved in, which helped kind of minimize the impact of some of these challenges. With regards to the social unrest, you remember back my slide about kids in NICH who are racial or ethnic minorities. And as you probably know, there was a lot of unrest going on in our community. And many of these families felt very vulnerable in Portland and the surrounding area. And so the NICH interventionists were able to make sure that they were safe and connect them with resources. So one person in the audience is going to scratch their head, if not several, about regression to the mean. This is just one patient in terms of regression to the mean. This was a patient with type 1 diabetes and also on the spectrum, ASD. And you can see at the second DKA, we approached the payer and said, we're really concerned about this young person for lots of reasons. And we have this program called NICH, will you engage? And they said, no, we got it. We have some care coordinators and some other things that we're gonna try to help with this family. We said, great, do what you can do and know that we're here. 14 DKAs later, they engaged NICH. And as you can see, the child had one hospitalization during NICH and hasn't had any since. We followed this young person out several months and they're doing great. And that one hospitalization had nothing to do with type 1 diabetes. That's one person, but we've also looked at our data in terms of multiple young people. These are also kids with type 1, 63 youth. And what we did is we looked at high-end utilization, PICU stays, hospital admits, ED visits, and hospital days. And what you can see is the year prior to referral in the far left-hand side of the slide, all those indices are down, but then when you see when they're on the wait list, everything goes up. So nobody's regressing to the mean. Actually, what's happening is they're escalating in terms of their utilization. And then during NICH, you can see they go down again, and then after NICH, they go even further down. What we believe is happening in this case is that doctors and nurses who know about NICH in Oregon are really in tune with what the true challenges are of these families. And as soon as they start to see risk, they make the referral because they're concerned and they're actually right on target because you could see the data shows that they're escalating. NICH is not for everybody. We want people to receive a lower intensity service and if they can benefit, we want them to go to it. We can't take all comers. And so there's lots of really good programs that we want patients to go to, young people to go to if we know that they can benefit from it. So if they go to those programs and their health does not stabilize, then NICH is probably warranted. And then the other reason that NICH might be warranted is if they don't engage in those services and they've fallen off the map. So NICH today, we've seen over 500 youth and families. We get 5 referrals per week, and we have 14 full-time interventionists. Research-wise, we have 10 published journal articles, 10 plus published abstracts, and we have over $3.5 million worth of grant funding. We are a continuity elective, a full-time continuity elective for 3rd and 4th year medical students. We're a catch rotation for residents, and we have Exito and practicum students. And then we've received several awards, Clinical Innovation Award from the American Association of Medical Colleges. EPIC has given us awards 5 years in a row for clinical innovation, and we received the first Press Ganey Pediatric Excellence Award. So funding, you know, we look at a lot of different avenues for funding, health innovation grants, obviously. We have case rates, it should be APMs, not AMPs. Case rates with payers, so single case allowances. We do program contracts with payers, so you know, maybe 10 kids or 20 kids, whatever the payer wants us to see. We've started using billing codes like G codes. We get foundation support. We do research grants and then hospital support. And all these things together really need to be included to keep this thing funded, because none of this should fall on the backs of any one group or source. It renders the program too vulnerable. And so we need to really diversify the funding sources, but also everybody in this has skin in the game. And so we need hospitals to step up. We need payers to step up. We need foundations to step up because it really does take all of this to fund this. We have a current JDRF grant looking at 5 sites, and UCSF is one of them. We're looking prospectively at 240 youth who have type 1 diabetes and are at high risk for repeat DKAs and excessive utilization, as well as elevated A1Cs. And that's an ongoing study. We're looking to see what social factors predict an escalation of A1C and DKA. We're also heavily funded by the Helmsley Charitable Trust. We started a collaborative with NYU and the Center for Healthcare Strategies to look at our data, and that is just wrapping up. Dave Wagner, our research director, has been intimately involved with that. And then currently what Dr. Lotish referred to as the dissemination in the Bay Area, which is heavily funded by Leona and Harry B. Helmsley Charitable Trust. It's being funded at Stanford and UCSF to the tune of about $1.2 million just for 1 year, with probably much more to come. And JDRF is looking to join the funding effort, but has yet to do that. Ultimately, we're looking for a national trial, but what's really exciting about UCSF's and Stanford's involvement is that this is the first dissemination outside of Oregon of NICH, and it's just an incredible effort. So people ask, who are the interventionists? Who are these incredible people? And they truly are incredible. You just have to have a bachelor's degree. We like people who are naive to healthcare. People like me and maybe some of you in the room, we're kind of jaded. We see obstacles, every reason why we can't do something. I don't want somebody in NICH. I want somebody in NICH who sees opportunity, is a problem solver, is a first responder. We like people with public health backgrounds. And ultimately, Kim Spear, our clinical director and co-developer, says, we hire for attitude, train for skill. And this is the team that you all have both at UCSF and Stanford, an incredible group of individuals from all different walks of life who are currently starting to intervene with niche cases at both UCSF and Stanford. So we couldn't be happier. Things are really moving along. It truly does take a village. And so I want to recognize the folks at Oregon, the folks at UCSF, and the folks at Stanford. There's a lot of people involved in this, and this has not been just a one person's effort. And this sits on my door of my office, and I take it to heart, as you can tell. This is one of MLK's most important and memorable quotes about how shocking and inhumane inequality in injustice in healthcare is. So this is my crew, and just to give a shout out, my lovely wife in the picture, we've been married for 32 years today. So this was a really nice anniversary present to be able to speak to you and share the successes of NICH.
Thank you so much, Michael. We have some time for some questions. And before we get to questions, I just wanted to say, you've really inspired us. And I think all of us as healthcare providers just see this as kind of the right thing to do. And the 4 interventionists that we've been able to hire, it's heartwarming because a number of them are former patients from UCSF who themselves have type 1 and want to empower others and serve as an example. And we really have a very diverse group of interventionists, including individuals who are Spanish speaking, African-American, who can really help effectively navigate the challenges our children are facing. So anybody who has any questions, please enter into the chat box. And while we're waiting, I wanted to also mention that Michael mentioned the fourth aim is the well-being of providers. And one thing that we're able to look at in the study here at UCSF is we're surveying provider well-being before and after the implementation of NICH. And it'll be very interesting to see that outcome as well, which is often, I think, overlooked. Okay, so we have a question. Fantastic work and thank you for your efforts. The model makes immense sense, but obviously faces challenges in a system that rewards FFS as opposed to health promotion. A question, when you cite the difference in expenditures pre and post NICH, is the cost of running NICH included in the figures?
Great question, and no, but we don't get paid that much money to do NICH. If you take out the cost of NICH, you're still seeing a pretty significant ROI to the tune of about $10,000 to $15,000 per patient per year. And remember, our data is also showing that once NICH is no longer involved, you continue to realize decreases in cost, and those costs, you're not paying for any services after that. So, but yes, the difference is between, it's about $10,000 to $15,000 per patient after you account for our costs.
And I guess in the last couple of minutes, Michael, one of our challenges is that right now we have generous funding for this program from different organizations and individual benefactors, but we really want to make sure that we can make this sustainable. So what is your vision for how we can engage stakeholders to make this a reality?
Yeah, that's a great question. So what's been really encouraging about our work down in the Bay Area is that the stakeholders that we've engaged are they get it. They're already champions. They understand the challenges this population has, and everybody's looking at ways to keep this going. Back to my slide about funding, I think this needs to be a joint effort. It can't just fall on the shoulders of Medicaid or insurance companies. It can't just fall on the shoulders of institutions like UCSF and Stanford. Everybody has skin in the game here, and so the best option is that we work collaboratively across institutions, across payers. You know, as I understand in the Bay Area, it's very much like in Oregon, that these kids bounce back and forth between institutions. And so everybody's taking a hit here and nobody really has an answer. And so if we work collaboratively, I think, I know that the chance of reducing the spend for everybody will be realized. Including foundation support, foundations from both institutions, because foundations offer support for non-medical things that families need that have a profound impact and direct impact on the child's health. And so we've been able to do that here in Oregon. And then lastly, research grants, or health innovation grants in the community is another way to contribute, or at least keep this program like this sustainable. Let me just say one last thing, if there's not other questions, is if you think about, one of the things I've been always curious about is that if you come into one of our institutions with a complex or chronic medical condition, we throw at you the best, right? We pull no punches when it comes to providing medical care. We get the highest level of care to everybody. When somebody comes into the institution with the same level of social complexity, we start with the least intensive, and we scratch our heads as to why that doesn't work. NICH is completely opposite. We are matching the intensity of the intervention with the challenges and the intensity of the social milieu that patients are coming from. There really are no shortcuts with this population. And so either you invest in a more intensive program to help these families and match the intervention with the level of need that families have, or you continue with the same model that we have in place both in Oregon and across the nation that is really not helping these families, because these kids keep coming into our hospital, these kids keep dying, these kids keep having profound catastrophic health issues because the system is just not built for them.
Well, thank you again. I wanted to add that if any of you folks in the audience want to follow up with us afterwards, also we need partners throughout the institution and outside of UCSF as well. And we have some folks who are in oncology who are working with us to try to get NICH to our pediatric cancer patients, and potentially rheumatology is also interested. So we're looking for more partners to spread this program.
I think we're just after 1 o'clock, so I want to also add my thanks for a fantastic presentation and just fantastic work. I'm really glad that we got to learn about your program. Dr. Hirsch, I think, had to hop off. So on behalf of Dr. Hirsch, thank you. And to everyone in the audience, have a great afternoon, and we'll hope to see you during next week's Grand Rounds.
Great. Thank you for having me.
Thank you.